Dr. Piga, for many years you come to São Paulo, and it's always a pleasure to have you, and your presence brings us hope for scientific development. So tell us a little bit what's happening in the thalassemia community.
Thank you. I'm very happy to be again here in São Paulo, but also, and more, very happy to have good news that are facts, are not just hopes, but facts. Because in the last 4 years, there has been so many advances for thalassemia that was unthinkable or incredible in the past. We have to work a lot, but there are many new things. And one is a drug that is now approved in US, approved in Europe, approved in Brazil. That is, the name is luspatercept, that is available, is expensive as any new sophisticated drug is, unfortunately, but is effective. Is not a cure, is not taking out the thalassemia. So it's not a full cure, but it improves a lot the transfusional need. So if a patient takes luspatercept and is a responder, because obviously, as for any drugs, there are responders and not responders. If you are a responder, you start to take this drug and your transfusional need go down, let's say something around 40%. In some cases, more than 40%, it is 60, 70, a few cases, 100%. So no transfusion at all, but just a few. Or a few cases, no response at all. So ideally, any patient with thalassemia that doesn't have a contraindication, we say, that are things against taking, should have the chance to try, to test. Just a few injections.
Do you know in advance who will be responder?
Oh, this is a great question. No, science today doesn't know in advance and to predict response or not. We tried everything, every test, everything, every calculation, but we don't. Okay. We do have the chance to see if the response is coming in shortly, briefly. So it's, let's say, in 3 months, we have the full answer.
Okay. And what exams people have to do to know after 3 months if they are responders or not?
So there is no need, basically, there is no need of so many sophisticated and expensive tests. Because if I am a thalassemia with regular transfusion, it's enough just to look at the result. So it's good to have to quantify very well what I'm doing, that is how many units, how long in the previous 6 months, 1 year, 3 years, very, very well. Then when I start to keeping the same hemoglobin, obviously, going on with the same hemoglobin level that I need, that I have, to see if when I come back for the transfusion, my hemoglobin is unexpectedly higher. And so I have to wait a few days to have again transfusion, or to have less, instead of 3 units, 2, instead of 2 units, 1, having the luspatercept and then go on. Basically, simple.
Okay.
If you can, we suggest to have the blood markers of the activity of bone marrow that are a bit sophisticated, are not for a very simple basic lab.
Okay.
But in larger hospital, in a large lab, it's possible to have.
Okay. And what about images? Because a percentage have to take care of extramedullary masses.
Sure.
So is this something they could try before starting? Take a tomography and then a few months later, how do you recommend?
I strongly recommend to do, in any case, to have we say, baseline, that if I'm planning a change in my life or a change in my treatment, I should not just decide yes, no, and then start and let's see, but just to prepare. And to prepare the best is to have a very strong baseline paramount. That is, and first is to have just a check. Do I have extramedullary masses? Very common in thalassemia. Normally very small, silent, but if the doctor is not checking, the patient doesn't know.
Yes.
So maybe that you start luspatercept without checking. After some time, you have a test, you have an MRI, and there are masses, and you see, oh, the luspatercept is causing me masses, so it's not a good drug, but the masses were there since many years.
Yes.
So to check before any important change
Yes.
in treatment is a very smart
Tomography.
idea ever. Yes, tomography, it depends on what you need. If you need just to know, masses, yes, no. And the size, MRI, it's enough.
Okay.
If you need to have the dimension very precise, that is, you need something more, that is tomography, but you have a lot of X-ray. So it's about, you may decide with your doctor about what is MRI, it's enough to know. If you have a special condition, large masses or other problems, it's better to have a very precise at baseline. If not, MRI is enough.
And Dr. Piga, I was talking with a Greek patient, friend of mine, and they say in Greece, the recommendation for blood transfusion is 11 of hemoglobin. In Brazil, most of the patients, they go between 9 and 10. Do you think 11 is needed?
No, the Brazilian way is right. I'm going to Greece in a few days. They invited me for a meeting. I will go.
Okay.
And I hope they will discuss the hemoglobin. It's not 11. It's not 11. That is, it's a long story. Anyway, in the past, many years ago, there was a study that showed that the best for thalassemia was to inhibit the, let's say, thalassemia bone marrow activity very strongly. So the suggestion was to have the pre-transfusion hemoglobin 11 or even 12. They call it super transfusion. It was a study from Boston, from a very, very clever group. I was a junior doctor. I trusted the study. And so we set for 1 year this super transfusion, and was wrong. But sure, today we know that to push up too much as a standard, not in special cases. Special cases maybe, so. But as a standard, to push up too much, the transfusion is wrong, is not the best. So
Okay.
9,
10.
9.5, 10, possibly personalized.
Okay.
Each patient with thalassemia is different from each other. Genetically, maybe different mutation, and also from other things. So the best is to have my ideal pre-transfusional level. If it's 9.2, please, I will try to be very regular at 9.2, but
Okay.
11 is now.
Now chelation.
Yeah.
Chelation. So still we have 3 chelators available. That's from generic with Ferriprox and exchange. And so, is there a preference? Do we know in advance what is best for each patient?
Yes, the answer is that the three drugs are different, each from the other. They chelate the iron. They are very good drugs. Each of these three is a very good drug, but is different from each other. So it is a good news because it's possible to have for an individual patient, that is your question, to understand which of the three is the best for that patient that is different from another one. First. Second, if there is a need, it's possible to combine two of these drugs, so different combination, in a smart way that is not to push up the doses, but to combine to have the best result. Because as the drugs are different, they do not compete for the iron, but they help each other for the iron. Very good.
Okay.
In example, the Ferriprox, is entering the cells very easily because it is a small one, enter the cell, take the iron, go out. If out, that is in the
circulation,
let's say circulation, there is one of the other two, it grabs that iron easily from the ferripron, and the ferripron is working more. So but you cannot decide as a patient or as a doctor in theory which one is the best. The doctor must have experience.
Okay.
And be balanced. That is looking just at the best for the patient and not looking at other points, companies, and other things. The patient and the best. And today is possible with experience to decide at the best.
Do you think it's interesting to change time by time? Let's say, do a period of combination and then switch drugs.
Absolutely, yes.
Yeah.
But on long periods,
Yes.
to change every 3 months,
No.
1 month, is stupid. Sorry to use this term. But long period and thinking in advance and design in a smart way, that is possible. Also for the safety on long term is good because the three drugs are very potent and good. But each one of the three, as we say, a small margin between efficacy and toxicity is small in general, because to chelate the iron is very difficult thing. And there will not be no new iron chelators in the next, let's say, 5 or 10 years. It's very difficult to make. So, but if you are expert, you can calibrate in a patient exactly the dose, and then you can think how to combine and how to change. That is possible.
Okay. What else would you like to say before we end?
Gene therapy.
Yes.
Gene therapy.
Gene therapy.
Because for gene therapy, there has been so many news for thalassemia.
Yes.
Good news and bad news at the same time. That as in the past, because gene therapy for a genetic disease like thalassemia is since I was very young, was that gene therapy. Today, gene therapy is a fact for thalassemia that has been approved in Europe in the past. A strong approach of gene therapy, we say gene addition, that is to put the normal beta gene with a viral vector, approved. So during the discussion with the countries, the approval in Europe is European, and then each country has to interact and decide the price and blah, blah, blah.
Okay.
So what happens?
So, just to interrupt.
Yeah.
Can you explain how it works, gene therapy?
Yeah.
What does it mean,
Yeah.
gene therapy?
So gene therapy is a sort of we say as doctors autologous transplantation. Autologous means to take your cells from the blood, very simply, your cell, a sample of blood, then select the stem cell that are the cell able to make a new cell. Select and culture in the lab, and then to have in this cell by a viral vector inserted the normal gene for beta globin, that is. So your cell will be corrected in the lab. And then simply to give back your cell corrected stem cell as a transfusion.
Okay.
But before giving back your corrected cell, we have to condition, that is to give you drug to remove the bone marrow, to have a bone marrow as an empty, nice apartment. So
chemotherapy.
Exactly the same. So there is some risk. It's a strong. Anyway, after that, what happened? That your cell, correct, will go and stay in place in your bone marrow and generate a new red cell, but with the normal gene. So, in this way, is a perfect cure.
Yes.
And today, in the world, there are around 40 patients in the world that has been cured in this way, and they are okay.
Nice.
The not good news on the approval in Europe was standing there. Then there was discussion on the price because this treatment is very expensive and some side effect in some of the patients. Not thalassemia, but sickle cell patient, because also this program is okay also for sickle cell. So what happened? That there has been in Europe a suspension, and then the company withdrew the program, saying no, we will not gain back the money we spent to develop. So, and they went to US. And do you know what happened in August 2022, just a couple of months ago? The FDA of US approved this treatment. So now the US thalassemia patient do have this treatment, and the cost has been fixed at $2.8 million. That is today is the most expensive cost for any treatment in the world of any type, even cancer is the most expensive, but has been accepted. And you know, US is working on insurance company that. And they are relatively happy, even if the cost is high. You know, there is a scheme not to pay the entire price if the effect is not 100%. So to go down, and that is so that is crazy. Nice. Because approved yes or no, approved yes is crazy. But the other good news is that another approach of gene therapy, we call gene editing, is running very, very fast, very fast, because is smarter, a bit safer, and cheaper of what we said.
Okay.
That is not approved at all in any country in the world, but I guess that, let's say 1 year, 2 years, we will have some approval. This is, the approach is not to force with the viral vector, to put the normal gene, but is just to take your cell, again, they say, take your cell from the blood culture, and then in the culture, do a thing that is to have with gene editing that is, let's say, a system to browse your DNA and locate a gene, a specific gene that is not the gene for the hemoglobin. Is the gene that is called, I tell you the name, BCL11A. That is the main gene that is responsible to silence the fatal genes for fetal hemoglobin that in every one of us are silenced at birth.
Okay.
We, during pregnancy, as fetus, we make fetal hemoglobin with special genes.
Okay.
That is perfect because it's able, the oxygen capacity to take is more than the standard hemoglobin. So we take the oxygen from the mother blood, and it's fantastic. But when we are born, we don't need that hemoglobin. It's good, but it's not perfect for adult life. So there is a very sophisticated way to switch off these genes. And the main responsible for this is this BCL11A. So it's by far simpler, faster, cheaper to take your cell and to silence that gene. So you have back your cell corrected, so they will make red blood cell, but with the fetal globin gene activated again.
Right.
So you will make fetal hemoglobin, but it's very, very effective. So you have, let's say, 13, 14, 15 grams of total hemoglobin. That is fetal hemoglobin, that is okay. You can run the marathon, but it's okay for normal life. The bad news on gene therapy, the first one and this one, what is? The safety on long term.
Yes.
Because it's a very potent way to go specifically where you need a correction. Yes. And now the result in terms of efficacy is easy.
Yes.
And will be approved also the second and possibly a third and the fourth method to do. Efficacy easy. But the safety is not fully in now. Why not? Because it cannot be this method, even very sophisticated, are not able today to be 100% specific. So it's possible to have some correction or change in your DNA in some other part, some other gene. So, but the safety today is not 100% in. Why this? Because even if this new sophisticated way to go to your DNA and correct are specific, but they may also give small changes to other part of your DNA, and these may predispose to bad things. We say oncogenesis, that is. And so I'm sure that the safety will improve progressively in the next few years. But today it's a challenge to say, okay, let me have gene therapy and I'm happy with that. So it might be a very personal decision, even if approved.
But the important thing is that there is hope for the new generations.
Yes.
It will be much better and easier to treat thalassemia in a decade from now than our generation. So I'm very happy.
That is very
And Dr. Piga, one project that we would like you to participate with us is discussing the cases of patients with the physicians and orienting the physician, changing experience and helping them decide what's the best treatment for each patient.
That is,
would you like
to
support us?
Absolutely, absolutely.
So,
I am very fond of this. Thank you.
So we will keep in touch.
Okay.
Thank you.
Thank you. Thank you, Merula.